Good afternoon, everyone. A very warm welcome to all of you joining us for the Acchutha Inspire Series 22. We are truly delighted to have you with us for the inspiring session. Please excuse me as I'm dealing with a sore throat today. It is a matter of immense pride and honor for me to welcome Dr. Anuradha, who is my principal during my academic year, and I feel truly privileged to have her with us today. Dr. Anuradha is the principal of Elite School of Optometry and the head of school children's eye health and community. She holds a PhD in community optometry, a master degree in psychology, and a PG diploma in health economics. She is a diplomat of the American Academy of Optometry and the fellow of Association of British Dispensing UK. With over 2 decades of experience in teaching, research, and clinical practice, she has made a remarkable contribution to community eye health. She has led large-scale initiatives such as the research program screening over 1 million children and has been instrumental in advancing school eye health across India. Today, we are truly fortunate to learn from her vast experience and insights. I once again extend a very warm welcome to you, ma'am. Thank you for joining us today. Over to you, ma'am.
Thank you, Shamla. It's so nice to see, your own student inviting you for a session and then being there. And Sharanya used to be my teacher when I was in Sankara Nethralaya. So I'm glad the other way also. So she used to be our clinical training mentor. So glad to have both of you here, and I'm in between both of you. So it's nice to be here back. And I don't know whether the students, you're not supposed to keep your videos on or something, I don't know, but I would like it if somebody can keep your videos on. It's good to talk to some faces rather than to the icons always. I would be happy if you could do so, and I will start sharing my screen.
Yes, ma'am. Thank you, ma'am.
Is my screen visible now? My
Yes,
screen is
ma'am. Your
visible?
screen is visible now. Yes, ma'am.
Shall I start? Shall we
Yes, ma'am. You
start
can
now?
start.
Yes,
Yes, ma'am.
thank you so much. Thanks a lot. And this is the topic that I would be discussing with all of you for the next some minutes. Niche optometry research areas leading to evidence-based practice. I want everybody's attention to all the words that I have used here. Niche optometry research areas leading to evidence-based practice. So niche is something that I want you to look at. And I also want you to think about the different optometry research areas that you might have in your mind, or you might have listened to others. And evidence-based practice. That's the other word that I would, phrase that I would like you all to remember. So let's go one by one. I wanted to give you an overview of what I'm going to talk today, but I don't have a point by point overview as to, okay, I'm going to talk this, talk this, talk this. Rather, it's going to be like an interlinked story. So yesterday night I was doing this only, and sorry, Shamla, I had taken a long time to give you the questions and other things that you had requested. But this is what took me some time, because every time I make a presentation, I also go back and look and understand what we are doing, how it makes sense, and how it makes sense to some specific aspects. So this is my overview. I know it's a very busy slide, but I wanted to see the connection that I'm going to take you through, and which led to evidence-based practice that I have been doing. So bear with me. At the end of this session, I assure you, you will understand everything in this busy slide. But just see what I have done. Please see the names that's written here, and please see what the connections are going, which one is getting connected. So please take some seconds, few seconds, and have a look at it. My suggestion to you is to start with the uppermost red color community optometry, and then you see how the different lines go to different places. So this is the overview of my presentation for today. I deliberately made it this complex so that I want you all to understand that research is not always standalone. It is always integrated and interconnected with many other disciplines that you are part of, which is what I wanted to make you all, understand, learn, and appreciate from this slide. Again and again, this slide will be appearing in my presentation, and I will make sure that you all see each and every aspect of this slide during the course of my presentation. Before going into the actual presentation, I wanted to show you what niche means. This is just an AI definition of the niche. A niche is a place or position that's particularly appropriate for someone or something, especially due to being very specific and different from others. So I want you to remember my title of today's presentation, Niche Optometry Research Areas. So what is this niche that we are all talking about? Something appropriate for someone or something. So what is the appropriate optometry research area? I know many of you would want to do research in contact lens, low vision, binocular vision. Yes, but what is very, very appropriate for someone in this profession? Because it is very specific and different from others. That is what niche means. And I would take you through what niche is for optometry research according to me. This is my personal opinion. And this is World Council of Optometry's concept of optometry. The definition, I'm sure you all have seen this definition multiple times in different forums. It's a healthcare profession that is autonomous, educated, and regulated, currently being done. But I want to emphasize two things. I really don't believe that this is the definition for optometry. I feel that this is more of community optometry because of this particular word that I see here, primary healthcare practitioners. So it clearly says optometrists are primary healthcare practitioners. Why are we primary healthcare practitioners? This is what, according to World Health Organization, is primary health care. That means it's a societal approach to ensuring that everybody is healthy and everybody's well-being is taken care of at the place closer to them, because it is easy for access and it is affordable, and it should also be comprehensive. That is what primary health care is all about. So now I'm trying to establish a connection, if you all can understand that. I said niche optometry areas leading to evidence-based practice. Now we also saw what niche is, very specific, appropriate for someone or something. And we also saw optometry's definition is basically of primary healthcare practice. So connecting these things, I believe truly that a niche area of optometry starts something with closer to community optometry, and the research should be revolving around this community optometry, which will make us very evidence-based primary healthcare practitioners. So this chain of link is very, very important to understand what I am going to tell you. I will repeat again. Niche optometry research areas are very specific, very, very appropriate for a particular profession, which is optometry. And I believe as optometrists, we are all primary healthcare practitioners. And the World Council of Optometry definition also agrees with all of us. So the niche research area should start from primary healthcare. This is what I truly believe in. So primary healthcare should be accessible, it should be affordable, and it should be comprehensive. So whatever we do in primary healthcare, we should also remember that we are ticking these three aspects. So my research interest areas, which I'm going to share with you all, which I feel is appropriate for optometry, will show you how it is accessible, affordable, comprehensive, and aligning with the definition of optometry. So we are going to see niche optometry research areas that are very appropriate for primary health care at the doorsteps of the community. Now let me go back to the same slide again. I want you to look at it now with a different eye. So the different eye and different vision. And I want you to look at the top most community optometry and see the different names. It starts with epidemiology. I'm also starting with epidemiology because this is how we started our community outreach research, and this is how we started our primary healthcare evidence-based practice. To tell you, SNCs is Sankara Nethralaya School Children Eye Examination Study. So when we started, that means when the school screening was started with Elite School of Optometry, specifically taking care of children-related activities at Sankara Nethralaya, it was close to the year around 2009-10. We started doing only children-related activities. That time, when we look back at the prevalence of any information relating to children, there are only two studies. In 2002, there were two studies that told about the prevalence of rural prevalence of vision impairment and refractive errors by Dandona et al. Dandona is an alumni of Elite School of Optometry and a close friend of Sharanya, And then followed by one Professor GVS Murthy's publication on the prevalence of refractive errors and vision impairment, which is from the urban location in Delhi. So 2002, after this study, there were no major publications on understanding of the epidemiology of eye diseases among children. So that's when we thought we should understand the prevalence currently around the year 10-11 when we started doing. But then when we started publishing, it took us so many years to culminate and consolidate all the information and data. And we published our first ever epidemiological study. This was in the name of SNCs. You can see status of eye health among school children in South India. But it took us almost 10 years to publish this because we had to streamline many aspects of the school eye screening, because that time people were only checking for refractive errors. So we also started like that with the prevalence of refractive errors, and then we also screened for the other ocular problems. Teacher-based screening was predominantly used. We changed it to a different model. We said that optometry institutions can take care of the screening. So we brought about a lot of changes during that time, and it took us almost a decade to publish our first paper on the epidemiology of school children. But this showed us that there was a very significant change in the prevalence of the vision impairment and refractive errors from what it was published in 2002, a decade back, to 2021, 2 decades after. We saw that the prevalence of refractive error is almost 4.42%. And we had both rural and urban arms with the 91,545, almost a lakh of children. And you could see in the rural region, it was 2.92% of refractive errors. So a stark difference, and we could establish it with a single study, which is the SNCs. But did we stop there? We also wanted to understand about the other prevalences. We also wanted to understand the difference between the general population, rural locations, and also the tribal locations. We started screening children in the tribal locations, and we found out, if you can see here, the prevalence of refractive error is only 0.3% that time in the tribal school locations, whereas 4% and 2%, and you see in the tribal locations it's only 0.3%. Such was the stark difference. So from then onwards, we started sharing this information in multiple forums, saying, oh, see the difference. It is not uniform across the country. If it's an urban location, if it's a rural location, or if it's a tribal location, the prevalence of refractive errors or vision impairment among children in India is very, very different. So we started accumulating such information. And then you can also see the this is one subject that nobody has no tried to screen because there is no treatment available. Color vision deficiency was not screened at all for many logistical reasons and for the reason that there is no treatment. But we wanted to see whether what are these children with color vision deficiency are doing, whether they are appropriately selecting a career which is right for their condition. Because very often we see many people coming to the hospital reporting at a very later age after they've got an offer letter for a job. They are rejected in the job because of their color vision deficiency. So we wanted to make sure that we screen the children for color vision deficiency, and we also wanted to make sure we counsel them appropriately for the right career choice. But before that, what was needed? How many children are affected like that? We found out that the overall prevalence was almost 2.76 percentage among the school going boys in South India. So this was a very big number because world over, the boys seem to have anywhere between 2 to 8 percentage of prevalence of color vision deficiency. And we thought 2.76, though it's on the lower side, considering the population number that we have, it was very huge, and we had to counsel them immediately, though there were no other treatments available. Did we stop there? We also wanted to understand what's the profile of ocular conditions. What are all the different conditions for which we need to refer the children? And what is the percentage that we are looking at? We found almost 2%, 1.96, you can see here, 2% of the children were identified with different ocular conditions, the predominant ones being high myopia, strabismus, and amblyopia. You can also see in the National Survey of Vision Impairment and Blindness, which was released by the Ministry of Health and Family Welfare, that amblyopia is the predominant reason for referrals or for the vision impairment in children. We could also align with it predominantly showing high myopia, strabismus, all that could lead to amblyopia. And you could see the prevalence here stated for every condition that we referred. So these information kept on accumulating, and we were happy that we could generate evidence for the very common ocular conditions that's prevailing in the community among children. And then what happened? We were continuing with this information. COVID came, and then everything changed totally, dramatic change in the prevalence numbers. What we saw as 4% before, we could see that the prevalence of refractive error jumped to almost 19% of myopia alone when we screened them in 2021, just after COVID. We immediately published this. We wanted to document this evidence because there were no other data coming from India about the school going children. But this gave a very clear idea that, like many other countries in the world, India also saw a very steep increase in the myopia. From 4%, it went up to 19%. Such was the huge jump. And now what are we seeing? We are past COVID for almost 4 years now. And we could see that the prevalence is dropping down. It is not 19%. But you know what's the surprise? It didn't drop to the pre-COVID levels of 4%. It is now anywhere between 8 to 10% among the different groups of children. We have also submitted this recently, and it is under review, that we are showing the myopia trends. And all of you have heard this famous statement that 50% of the world population is going to be myopic, and India also is no different. There was a paper that cited this. But what we found out from our data, I'm sorry, just a minute. So what we saw from our data was that the previous publication that was there, which showed that 50% of the population children would be myopic. This came from India. That was more of urban children. The prediction was based on more of urban children. So we wanted to see whether we will definitely become myopic. 50% of our children will become myopic. We included data from public school going children and urban children, private schools, everybody included. So we saw that we were screening the predicting the numbers from our data when we included both public school and private school, because if you know, a majority of the children in India are studying in public schools, which is like almost 67% are in public schools, and the remaining small percentage is only in the private schools, so which is in urban location. So if we only extrapolate the data from urban children, where we all very well know that no, urban school children will have more prevalence, we will not be representing the entirety of all different types of children in our country. So we have again submitted this, and we are showing a different trends. Once we have the paper published, we are going to share it with you very soon, maybe in the next Inspire series probably. So the steep rise in myopia changed the outlook with which we started looking at the information that we have in hand. So now no more it is 4% prevalence, it is almost 8 to 10% prevalence even in the public school going children, whichever we are screening in the Chennai, Tiruvallur, Kanjipuram and other locations that we are looking at. And then like this, we started creating evidences that is from the community, from the schools, from the first step of healthcare system for children. Then we thought, okay, so many children are having no, prevalence is increasing. We also thought about incidence and progression. What is the incidence? What is the progression of myopia? You would be surprised to know that through a study called as STEM, we found out almost 5.5% of children are developing new myopia every year, and almost 30% of children are progressing every year. No, it was a very shocking information for us, and we know that there are a lot of spectacle based myopia management options that are available, including DIMS. So what we did, we wanted to see when this DIMS was introduced. This was very early, this is almost 2 years old now. So when DIMS was introduced, we wanted to understand the quality of life of children with DIMS. So though my heading says epidemiology, this was a precursor information. I am slowly showing you the transition from the prevalence information, we wanted to understand the qualitative study or the patient reported outcomes of some conditions in particular. So this, it was not a condition. We wanted to understand how in myopic children, how the dim spectacles improved or had an impact on the quality of life. So this was published very soon after DIMS was introduced, and we wanted to understand how the children feel. It was showing all positive domains. We used the WHO's quality of life framework for understanding this. And we showed that in most of the domains, this DIMS performed well, except for some domains which they could correct it later. So we also had a series of niche areas, PROMs as patient reported outcomes. Often the epidemiology or the quantitative research is all like numbers. Qualitative research is all about textual information. What the patient told you in their own words, you submit it as results. So patient reported outcome measures is PROMs. So there are a lot of any new studies, any new research studies, any new randomized control trials, people insist on now PROMs, patient reported outcomes. As an experienced practitioner, as a researcher, you would give some results, but that alone is not sufficient to prove that a treatment works well. Now, patient reported outcomes are very, very vital. So that is why we started doing the DIM study, and then we started doing the DIM study, and then we understood the quality of life. Now, with respect to Prompts, what else did we do? We never stopped, or we never believed that only clinical practice or community outreach should be evidence based. We also believe that education should also be evidence based, and like patient reported outcomes, any beneficiary or any stakeholder could report their outcomes. So if you are a student, you are studying, whether the education is good or not, as a stakeholder, you have a say. And what you say matters the most. Like how in clinical care, what the patient says matters the most. Whatever the student says matters the most in an educational setup. So what did we do? We did a qualitative research. Actually, this is a mixed method study that we did with the Deakin University. We did what is called as international placements, like how you go and attend the patient, see the patients in the clinic, and you discuss with your faculty and mentors about the cases. We created a virtual environment for these students from both India, from our institution, and Australia, from the Deakin University. And the students will present a case on a platform. A common case will be presented, and then the students and the faculty from both the sides will facilitate the discussion, leading to understanding of a condition better. This we published based on the feedback that we took from the students and the faculty. This is a mixed method study, that is both the qualitative and the quantitative research was present in this. This was an evidence-based practice that we implemented in the educational front. So by evidence-based practice, I am not restricting myself to only clinical practice or community practice. It is also integrating education with niche optometry research areas. After this, what did we do? Again, jumping back to the clinical areas. First, what I showed you was a clinical one with the quality of life study with DIMS. The second one that I showed was on education, where we did a qualitative research. The third one that I'm going to show you is the PhD work of Dr. Ramya. She studied what is called as falls as a behavior and how to prevent falls. Falls meaning falling down. No, falls, how to prevent it among adults with visual impairment. And what we did was, we didn't stop with doing interviews and then trying to get the results from the stakeholders, which is the beneficiaries. We also used a framework, different frameworks. We call it as COM-B model or a behavior change model, because behaviors are very difficult to change. You need to follow a systematic method of doing things. Now, not many of us know that behavior change is an important aspect in any clinical practice. What is this behavior change that we are talking about? Suppose you prescribe spectacles to somebody and they are not using it because of n number of reasons. You need to change their behavior. Behavior of compliance. You are giving an advice, you want them to be compliant, changing the behavior. Now you prescribed glaucoma medication to somebody and you want them to use the medication to safeguard their eye and their health, but they are not using it. So what will you do to change their behavior to be compliant with the use of the eye drops? So behavior change models have been very well used in many disciplines of healthcare, but often not given much attention in optometry research areas. So what we did, we wanted to see whether we can change the behavior of the adults with visual impairment. We followed a very systematic method using very specific frameworks to change the behavior of adults with visual impairment so that their falls can be prevented or reduced. And this we published it. Behavior change models using qualitative research is another niche optometry research area. After we published this, we didn't stop this. We also made sure that the learnings that we got were tested as an intervention. I will come to that. And we also developed survey form which we are using in the clinic for anybody, any adult who is coming with vision impairment to understand whether they have falls, how to prevent their falls. So we are doing a survey. So behavior change model through prompts is another important aspect. This is one of my oldest qualitative research. As I told you, as an example for spectacle complaints, we wanted to measure spectacle complaints among adolescents, like 14 to 17-year-old children, school children, and we wanted to understand why they are not using the spectacles that we are giving it to them. What were the reasons? You wouldn't believe that we got some 100 odd reasons for a child not wearing spectacles. We didn't stop with the children. We also got the same information from the other service provider also. If you see the previous one, the beneficiaries, the children and parents gave their the reasons for not wearing spectacles, and they also gave the solutions as to what will make them wear the spectacle. In the next study, what did we do? The same information, but we got the perspectives from the service providers, like eye care professionals, social workers, all these people gave their perspectives, and we integrated all this to better understanding spectacle complaints, what should not be done, what should be done to improve the spectacle complaints. So we came up with a 23-step intervention package from these two studies. This 23-step intervention package, we again tested it for effectiveness. Whether this 23-step will work, it will not work, we wanted to test. Similarly, when I told you about this false, after this study through the behavior change model, we came up with an intervention strategy which was called as SMART intervention strategy. SMART is an acronym. S is for support from caregivers, and M is for monitoring, like A is for assistive devices, like that. SMART is an acronym that we used. So we also tested the SMART intervention strategy through behavior change models. So qualitative research is an other niche area, or patient reported outcomes are a niche optometry research area that could change your practice. How did it change our practice? Whatever solutions that we derived out of these studies, we tested the interventions that were proposed by the stakeholders. So how did we test it? So this is another small tidbit information that I wanted to share. The content that we develop out of the qualitative research is what is made as a questionnaire. So if anybody wants to develop a questionnaire, the first step is to do a qualitative research, and whatever content you derive out of it, that is made as a questionnaire. I told you we use a false related survey for all our adults with vision impairment reporting to the low vision clinic. How did we get the survey questions? From the interviews that we made, we changed it to a survey. From the interviews that I made with school children, now we are planning to develop a questionnaire. So, okay, what happens after you develop a questionnaire? You need to validate the questionnaire. How do you validate the questionnaire for a specific population? Which is where rash analysis comes. Rash analysis is one of the ways by which you validate your constructed questionnaire and see whether it can be appropriately used for a specific population. What we did, this is a very interesting story. We did rash analysis for vernal keratoconjunctivitis questionnaire. There is a questionnaire called as quick questionnaire. This is already existing. Why VKC? Why not some other condition? I want you to I want your attention to the previous set of studies where I spoke about prevalence. I told you we measured the prevalence of ocular conditions, and I also showed you strabismus, high myopia, amblyopia, everything. One of the key referral reasons was vernal keratoconjunctivitis, and we found out that vernal keratoconjunctivitis was affecting the children, though the numbers were less and it was found in pockets of region. We found out that it was affecting the children because it's a very chronic condition requiring treatment for a long period of time. So we wanted to understand the quality of life in children who are affected with the quick questionnaire. This word quality of life, I already used it in the DIMS quality of life. This is the second time we measured quality of life in children with VKC for this time, because we found this to be a significant and a chronic condition that was affecting the school children. So remember the connection: children, community optometry, school children eye health, then prevalence of conditions where we found VKC, and we thought the quality of life of children is affected. We did quality of life with some other conditions, but we wanted to do quality of life with vernal keratoconjunctivitis. So we could have done a qualitative research, which we did, but ultimately we also used to validate rash is a niche optometry research area you can call to validate lot of questionnaires that are available. And so finishing with the chapter on qualitative research and then followed by questionnaires, let's come back to the effectiveness of interventions. I told you qualitative research gave us lot of intervention steps. So 23-step intervention package for spectacle complaints. So what did we do? We got some solution, but will it work? Will it improve the complaints? We need to test it. So we did a quasi-experimental study where we had one control arm, one intervention arm, and we tested whether the 23-step intervention will improve the complaints to spectacle wear and referral. And we found from 18%, it became close to 58% after we implemented the interventions. And still, this was published way back in 2018. And for 8 years now, we have been following every 23-step intervention in all our school eye screening, which keeps our spectacle complaints closer to 60 to 65%, which is way beyond the national average of spectacle complaints, which we are ensuring. So you please see that research gave us a solution, and that solution is bringing back, we are putting it back into as evidence-based practice back into the community optometry. So community optometry, we started with something and we wanted to make sure that the interventions that we are getting is put back into use in the same community optometry. What else did we test the interventions for? This is the Dr. Ramya's falls prevention study. I've just taken a screenshot. This is a picture which I love the most because it gives the results from 3 different frameworks. If you have time, you please go and read this paper. It is published in Optometry and Vision Science. We are showing you how behavior change model can be implemented. This is from 3 different frameworks. One is called theoretical domains framework. The other one is the COMB model, like which I told you, capabilities, opportunities, and motivations for behavior change. And the last one is the socio-ecological model. The names are all very difficult, but I will make it simple for you. You can see here individual, family, and society. So socio-ecological model will show how at different levels, different solutions need to be implemented. The boxes here are the barriers and facilitators from the theoretical domains framework. And this 3 shows the capabilities, opportunities, and the motivation levels that needs to be done. So from this only, we came up with the SMART intervention strategy. You can see here, the first one is yes, support from caregivers. The S stands for, the S is for support in the SMART. M is for monitoring falls. Like that, we came up with a SMART strategy, which we tested. And you wouldn't believe, we could reduce the falls in adults with vision impairment to almost 69% from what it was before. Already we did a quasi-experimental study. We had a control arm and we had an intervention arm. And by implementing the smart vision strategy, we could reduce the falls in adults with vision impairment by close to 69%. So this we tested, and whoever is coming to the clinic, with false history, we will be able to implement the smart strategy to reduce their falls. So what is got as evidence, we are putting it into practice now in the clinic. So niche optometry research areas, especially with respect to primary health care. Primary health care is prevention, promotion, cure and rehabilitation. All these things put together, then only it is comprehensive. Remember the three things: accessible, affordable and comprehensive. I am showing you how comprehensively you can contribute to primary healthcare initiatives. Going forward, I told you three things: accessible, affordable and comprehensive. We saw a few examples of comprehensive. I also wanted to show some examples of affordable. Whenever we do school screening, people used to always tell me, you are utilizing optometrists for school screening. That is very costly to have optometrists involved in school age screening. So I wanted to create evidence. I didn't believe the statement that people were making. I wanted to have evidence-based statement saying whether really optometrists utilizing optometrists in school screening is costly or it is not costly. So what we did a cost analysis of a comprehensive school eye screening model from India. You know what we showed? Using optometrists, utilizing optometrists and optometry students in school eye screening, it reduces the cost and we can also provide a comprehensive care. If a teacher is screening, they can only screen for vision impairment. But when an optometrist and an optometry student together as a team goes for a screening, they can provide comprehensive care at a much lesser cost. We were able to prove that with less than $1, we could screen the child, provide spectacles, do any surgery that was needed, provide vision therapy, and also counsel the children with in-person counseling for every aspect of ocular diseases that we found. So for such a comprehensive protocol, including compliance assessment, we were spending only less than $1 per child when we utilized optometrists and optometry students. So effectiveness not only comes with clinical accuracy or clinical good for the patient, but it also comes about affordability to the patient. So we showed that utilizing optometrists is good for the system also. Did we stop there? We also wanted to explore whether cost effectiveness could be extended to any other region, any other genre of clinical practice of optometry. We found that scleral contact lenses were very costly, and then giving the scleral contact lenses to patients, whether it is very costly, whether no think we were thinking about it. So we did a research on this and we found out, yes, it is costly. Giving a scleral contact lens to a patient, yes, it is costly, way above their monthly income, especially for the low and middle income families of India. But the benefits that they accrued, that also we converted into monetary outcomes, and we could say that the benefits outweighed the cost that were incurred by the patients. And we also advocated saying that we need to ensure some insurance initiatives that could be extended to these people from low and middle income so that their benefits could be exaggerated than the cost that would be incurred for availing such specialty contact lenses. So health economics is another niche optometry area. You cannot say, ma'am, I am not bothered about the cost. I am a clinician. I will only concentrate on the betterment. I will improve the vision from 660 to 66, but other things are not my genre. No, it is yours, because as a primary healthcare practitioner, it is our job. It is appropriate for an optometrist to think about how much my patient is spending on each and every treatment, whether I can do anything to reduce the cost by some means or the other. My expenses should be less and the benefits to the patient should be more. So which research area can give you an idea about this? Health economics. And all of us should be understanding some basics of this economics for the good of our patient, for the patients to afford the health care that we are providing. We didn't stop there. We also extended this to low vision care services, which is under review now. Very soon we will be coming out with this publication. And we are also doing cost analysis of our flagship program, which we call it a single day mass vision screening. In one day, we have a national record for screening 8,469 children comprehensively. But we wanted to see whether economically also we are doing good when we are doing the screening. One part is clinical accuracy, the other part is the cost aspects of it. We are also trying to find out whether amblyopia management, what is the cost, what is its effectiveness, whether anything needs to be done. So we keep extending the different research areas to niche optometry specialty practices, and establishing this link will ultimately help our patients also. Everybody asked me, ma'am, research means now everybody is doing different instrument development. Should I also involve myself in instruments development? By instrument, what do we mean? Everybody thinks about big instruments, OCTs, perimeters, and no, the ASOCT, that, this. Everybody talks about big things. But for me, my need determines what products I will produce. My need means my institution's needs, my community's needs, what is very immediately needed and what is under my purview, because not everybody could involve themselves into big product and mass production of instruments, finding a market for it. This is not everybody's job. So should I stop for anything? Shall I continue?
No, ma'am. Yes, ma'am.
Okay. So should I do every product that everybody is doing? No, I believe that I will do what is necessary for the community, what is necessary or what is possible under my scope, what aligns with my institution's vision. So what we did was, this was long back developed by our research team. This is a pocket vision screener. Many of you would have seen this. We developed this as a very quick, very effective screening tool for school children. It's just a card made of paper. We print it and we use it, and it reduces our time for identifying children with vision impairment. What else did we do as product? For me, product is something which is very simple, cost effective, and accessible to everybody. And then what else did we do? We worked with one of our alumni who himself was color vision deficient, and he wanted to develop a very quick color vision screening tool with us, and ESO and him worked together, and we were able to come out with this Dalton's color vision screener. So this, the original Ishihara, this is the principle is basically of pseudo isochromatic plates only, but the original Ishihara is made of plant-based dyes, and it becomes soiled very easily, and you cannot touch the Ishihara, and with multiple people using it, it is very difficult to maintain it, and the cost is very high, and replacing it every year is very difficult. So what we did, we made it out of a plastic polymer with the same principle, only 4 plates, which are the screening plates, and very quickly and very cost effectively we can screen for the color vision deficiency. So simple instruments, simple products, but makes a huge difference when for our primary healthcare practice. Is that all? No, we ventured into a new research area. Of course, this is not new for us. Way back in 2008, psychophysics lab was established by the elite school of optometry. After a brief hiatus, we started again. Now, this time, what did we do? When we go out to the community for screening, we also check for their phoria status, for their heterophoria. We wanted to document it. But when I do, when another person does, when a student does, there were a lot of differences in the way these heterophoria measurements are made. So we wanted to see whether this can be automated. So thanks to our research team, now we have developed a small prototype. We have used a video camera, and we can use it as a trial frame. We put it on a subject space, and it will record the movements when we are doing cover test, and there is a program written, and that can be converted into measurable heterophoria values that we use it here for identifying any non-strabismic binocular vision anomaly. We have submitted this and waiting for review now. We have constructed and validated. Again, this is a very small, cost-effective, lightweight instrument, and we are working to see how it can be integrated into our community outreach programs. So all these things I started with epidemiology and prevalence, and we went on to qualitative research, questionnaire development, and we moved ahead to other things like the products that could be done in this and effectiveness of interventions and everything. And then we came to health economics and then products. And we also see that in this process, we talk with many people, we discuss what all we are doing, and then we enter into different collaborations. Internally also we collaborate, like the one I told you, I am doing community outreach, health economics. I also collaborate with the contact lens clinic, binocular vision clinic. So internal collaborations and also external collaborations. You see this, this is now published, and this is a scoping review that we very recently published. You can see this is in late 2025. This was accepted, and we wanted to understand the model of school children eye health, and also the other pediatric refraction and spectacle dispensing practices in India. And we wanted to compare this with the UK, which is like a well-established healthcare system in that country. So these two models as to which are the best practices in both the places, we wanted to understand this. And for UK, we collaborated with Dr. Subhash, who is working with the National Health and here at our institution, and we could find out what is the best practices in terms of 5 P's, in terms of protocols, in terms of pricing, in terms of personnel who are involved. So in all these aspects, how India and UK are doing with respect to pediatric refraction and spectacle dispensing. The sequel of these papers are being written now, and we will come up soon with what we learned through qualitative and quantitative research from different practitioners across our country. Please wait for the updates. Now I want to introduce to you a new niche research area. This is called as health systems research. When you do something to change how the health systems are practiced, when you do something to understand the health systems, this is called as health systems research. So when you propose saying utilizing optometrists and optometry students are cost effective, you are changing the system of health. When you are saying, no, when somebody comes with vision impairment, adults, you want to give them a false prevention strategy, you are changing a clinical health system within your hospital. So this is a countrywide or inter-countrywide health systems that we are looking at what are the best practices. And then collaborations continuing. We started in the last 2 years, we started screening for preschool children. So new niche areas. We didn't stop with community outreach with school children. We are also working with preschool children now. We are trying to understand the status of eye health. We have named it SN6. And you can see we are collaborating with Dr. Aparna Raghuram. And very soon we'll be coming out with publications. We have already submitted some papers on this aspect also. We are trying to bring normative data for many of the visual functions for children of the preschool age. So soon we will be sharing those results with you. So this collaboration need not be again restricted to clinical practice or only to community outreach. We are exploring this with education also. We wanted to see how our international placements are breaking the boundaries and opening the borders by seeing how we can integrate multiple countries to being part of this international grand rounds that I was telling you, international placements with Deakin University, Australia. We were exploring whether New Zealand and Africa can join together, and then we can collectively discuss case of different optometry specialties. So this is collaborative research extended into optometric education also. This is a national collaboration. You can see all prominent educators of Indian education, optometry education system. We all joined together and we understood how our education is currently contributing to the eye health needs of the 3 billion eyes of our country, and what are the challenges and what are all the different areas of improvement that we could explore. This is a viewpoint article, again a collaborative research. So evidence-based practice should not stop with clinical and community practice. It should expand to more areas is what I am trying to put into your minds. So these are some new niche areas that I wanted to show you: health systems research, optometric education, preschool children screening. Now let's again see this. Now this slide might make more sense to you now. You can see how community optometry is where I started everything. Prevalence information through the epidemiology and how myopia became a very important part, and how different qualitative research and questionnaires were integrated by understanding different ocular conditions, and then how qualitative research we extended to compliance for many aspects, false prevention on many aspects, myopia management on many aspects, and how from each of this it went to effectiveness of interventions, and effectiveness of interventions again contributing to community through the 23-step intervention package, false prevention, health systems research again contributing to low vision care, and false prevention is also connected, you can see here, and effectiveness of interventions. All this doesn't stop with only effectiveness of intervention, but also cost effectiveness, and how cost effectiveness in school eye health, in community optometry we contributed, and how in low vision, binocular vision and contact lens it is getting extended, and how binocular vision we also integrated with instruments development for heterophoria measurement. Definitely without psychophysics, there is no experimental method. And I also am happy to share that from psychophysics and binocular vision, we are also extending it into sports optometry and evidence-based practice for sports optometry. So now I believe that this picture will make more sense to you. And of course, everything is integrated to education. This picture might make more sense to you now, and you will also see that many things are interrelated. Research is not a standalone entity. What you do in research comes to the clinics, comes to the community practice, and what you do in the clinic and community raises questions for more and more research, and everything you collect as evidence should be brought back to the education, to the students. Then only it becomes a really evidence-based practice for clinic, community, and also for education. So my take-home message, please remember that optometry is a primary healthcare profession. You should think about healthcare as accessible, affordable, and comprehensive, and collaborate, create evidence and consolidate the evidence. Be an evidence-based clinical practitioner. Thank you so much for patiently listening to me. I would be happy to take any questions from any of you.
Thank you for the insightful presentation and talk, ma'am. We can take a couple of questions from the chat box and through the Google form we shared.
If they are not asking questions, I will ask questions.
Yes, ma'am. You took me back to our public health optometry and visual optics class.
Sorry, ma.
You took me back to the visual optics and public health optometry class.
Thank you.
The first question is from Kavya Dashni. I would like to ask that what are the biggest challenges in translating research evidence into day-to-day optometry practice in India?
That's a very wonderful question. Who asked that?
Kavya Dashni, ma'am, from Acchutha Institute of Optometry.
Ah, very nice, very nice. Thank you, Kavya Darshini. That's a very wonderful question. How to translate this, whatever evidence that you are creating, into clinical practice? It is not very easy. It's a very big process. There is something called as, let me give you an answer based on evidence only. There is something called as APEASE criteria. Okay, APEASE, APEASE criteria. You can go see what APEASE criteria is all about. The paper on prevention, the false prevention that we wrote also has this APEASE criteria. Whenever you are having any intervention, you should check whether it fits into this APEASE criteria. I will tell you what happened during my spectacle complaints intervention. I told you 23-step intervention and all, no? I got some 50 odd interventions or solutions from the stakeholders. One of the solution, no, Kavya, what that was, one student told me in the school, give me one spectacle. One spectacle, the power should change automatically on its own every year. I don't want to go for eye checkup every year and all. Do you think this solution can be implemented? I can't see Kavya Darshini. Where are you? Do you think the solution can be implemented? Are you here?
Yes, ma'am.
What do you think this was a suggestion by the student from a school? Because I did a qualitative research. I asked him, no, what should I do? Why are you not wearing spectacle? I want you to change the power. He's telling it's very boring to go for eye examination every year. You give me a spectacle, the power should change automatically. I don't want to go for any eye examination and all. Do you think it's an implementable solution? What do you think?
No, ma'am.
Is she available, Shamla? Not a practically implementable, no. So this APEASE criteria will tell you what is practical, what is effective, what is safe that can be implemented. So whatever you are getting, before you make sure that it is made as evidence, you should see these criteria and then only suggest this as evidence. So when you generate such strong evidences based on this such criteria, it becomes easy to implement. When I told there is a 23-step intervention package, everybody asked me, 23-step intervention, who will be able to implement? It is not at all possible. It is not at all feasible. So I had to prove to them that it is possible to implement based on these criteria. It is practical to implement. It is effective. It is safer. No, all these criteria needs to be satisfied. If you do that, then I don't think anybody can stop you from implementing. But before you generate the evidence, you should ask yourself this question, whether it is practical, it is effective, it is safe according to APEASE, it can be implemented. Then you will be able to implement. I know practically a lot of challenges will come. They will say, no, it is not possible. But you be very stringent, saying, yes, it is doable, show it. I'll also give you another example. Okay. There was a research once when it was done in our institution. They wanted to see why not many low vision patients are getting referred to the low vision department. Okay. From the Sankara Nethralaya hospital itself, people visit different departments, but somebody has to refer them to the low vision department. So they identified the reasons and then they came up with a strategy. They brought something called as primary low vision clinic. In the OPD itself, no, some of the minor things can be taken care of. So you need to figure out of your solutions which is implementable and which is practical. All these aspects we need to look at. We cannot blindly say nothing is implementable. So very specifically, we need to measure those aspects, see the APEASE and then implement it. Okay.
Okay, ma'am. Thank you for your information.
I don't know whether Kavya Darshini is okay. Yes.
The next question is from Mridula from Acchutha
Any other
Institute of
questions?
Optometry. Yes, ma'am. What are the skills an optometrist should develop to balance and perform research along with clinical practice?
What are the
skills an optometrist
ways
should
by
develop?
which?
What are the skills an optometrist should develop to balance and perform research along with clinical practice.
The very thought that you want to balance research and clinical practice itself is very satisfactory. That is the first thing that everybody should learn. Okay. You should balance clinical practice and research. This cannot be done separately, that cannot be done separately. So I am glad that you have understood that a balance is needed. What are all the skills that you should develop? Lot of skills are needed. There is a one skill that is nowhere written, which is not a pure optometry skill and all. It's a human skill, patience. Okay. One is patience. Second is passion. If both are there, I am sure you will learn all the other skills. Okay. But the real research skills or other skills that you should be doing, you should have an open mind to look for questions. If somebody gives you a question, no, don't take it offensively. See whether there is some truth in what people are asking. See whether you definitely need an evidence to say that no, something could be done to change the mindset or the notion or the way that some things are practiced. When somebody told me using optometrists is a very costly affair, no, I didn't take it as a criticism. I took it as a feedback, and then I thought, is it really true? No, let me analyze it and find out an answer. So I had to balance few things. So, but for this to be done, I need knowledge about what I am doing. I need to keep an open mind as to what sort of questions I am hearing. Is this a good research question? For that, I need to be in practice. If I'm not in practice, I won't be able to understand the correct question that is needed for research to be done. So being in practice is first thing. Then what skill set I want, learn new things. I got my diploma in health economics, just 7-8 years back. I got my diplomate in public health just 3 years back. So lifelong learning is one. It's not a skill set, but it is a mindset that I am telling you. I would ask everybody to learn basic statistics and analysis. That I'm sure you all have to learn. But mindset, keeping your mind open to seeing what could be a good research question and how it will help the public. And then balancing will come easily. Open your mind, develop all lifelong learning, develop necessary skill sets on research and data analysis, then passion, most importantly, patience. Put all this in a jar and shake it. You can balance anything. Any more?
Yes, ma'am. Is a question through a Google form
Am I audible?
asked from. Yes, ma'am. I'm audible, ma'am.
Yeah, you are.
Yes, ma'am. Is a
Somebody else
question
is
from
talking, I think. That's why I was not able to hear.
is a question from Mr. Vivek from SRM University. Is there anything new or updated beyond the traditional 5A model when it comes to evidence-based practice?
Is there anything new from?
New or updated beyond the traditional 5A model when it comes to evidence-based practice?
As far as I know, there is nothing new apart from that. If I get to know anything, I will keep you posted, Vivek, definitely.
So there is a question in the chat box. Any beginners research guide?
Yes.
That you will suggest?
Beginners?
Research guide.
Beginners researchers know the basics. Yeah. I assume they are asking about what all they should learn again. So you should know the basics of the research methodology. You should know the basics of the biostatistics. You should also know how to write, scientific writing. So these are the sequels that I would suggest for beginners. I see Gopinath has responded, read basic RM books. So that's the sequel I was telling. Research methodology, then biostatistics, scientific writing. So please go in this order. Read more, discuss more about this. Okay.
Thank you for your time and consideration, ma'am. We can wind up due to the time aspect. Before we close, I would post it today's quiz link in the chat box. Do fill it and get OCI credit points, which is both signed by both Achyuta and OCI. Do fill and get the certificate. Thank you, ma'am, and thank you everyone for joining the session.